Hello, I'm Dr. Jenny Andrus, and welcome to another episode of Joint Ventures. In this OSC original podcast, we look critically at the latest medical news. We're here to help you understand the newest medical information so you can make informed decisions about your healthcare. One of the most common decisions patients have to make is about prescription medications. You leave the doctor's office with a new prescription and you get that book from the pharmacy with all of the side effects and precautions. For patients, the decision whether or not to take a prescription medication can be really complex. Is the medication going to help me? Am I going to have side effects? Or is it going to cause other problems or interact with other medicines? All important questions. And a recent study showing that a commonly prescribed pain medication could cause dementia certainly hasn't made that decision any easier. In the July issue of the Regional Anesthesia and Pain Medicine Journal, a study was published that showed an increased rate of cognitive impairment in patients taking gabapentin. All right, now let's talk a bit about what gabapentin is. The other name is Neurontin, and it is a widely used medicine for pain. Gabapentin is an anticonvulsant or anti-seizure medication, but it is most typically prescribed for pain, not seizures. It is the first-line treatment for neuropathic pain, so it's commonly used in patients with neck and back pain, sciatica, shingles pain, painful peripheral neuropathy, and fibromyalgia. Gabapentin works by binding to voltage-gated calcium channels in the nervous system. This reduces excitatory neurotransmitter release. It also is involved in increasing GABA levels in the nervous system, which is an inhibitory neurotransmitter. So, gabapentin works by decreasing neurologic excitability, which is how it reduces seizure activity and also how it reduces neuropathic pain. This study was retrospective, meaning that the researchers looked back at a national database and found patients who were diagnosed with chronic back pain. They excluded patients with dementia, epilepsy, stroke, or cancer. Then they looked at rates of cognitive decline or dementia in patients with chronic back pain who were prescribed gabapentin and those who were not. The authors found that patients with 6 or more gabapentin prescriptions had an increased risk of dementia and mild cognitive impairment. Risk increased more with prescription frequency. So patients who had been given 12 or more prescriptions had a higher risk than those with 3 to 11 prescriptions. The authors found that adults prescribed gabapentin for chronic low back pain had a 29% higher risk of developing dementia and an 85% higher risk of mild cognitive impairment within 10 years compared to back pain patients who were not prescribed this drug. The risk was doubled in patients over 35 years old. Okay, this seems exceptionally high compared to what I see in practice. So we're going to dig a little bit deeper into the study to see what it really is and isn't able to determine. This type of study has a lot of drawbacks, particularly in that these large database studies are not able to determine a specific causative factor. There are just too many variables not accounted for. One big limitation in this study is that they looked at how many prescriptions were given, but not the dose or the regularity of use. Also, patients routinely do not take medications as prescribed. We don't even know if the prescriptions were used or not. The study doesn't give information to stratify risk in different doses of gabapentin or for different durations of use. We just have a number of prescriptions given, which doesn't tell us much about the use of it really at all. It also gave really no other information about the subject's health. Other than excluding people who already had dementia or stroke, they don't tell much about the subject's health at all. So, for instance, if many of them had type 2 diabetes and peripheral vascular disease, they would be at an increased risk for vascular dementia, which is due to poor blood flow to the brain. I see several patients a day who have painful peripheral neuropathy from diabetes, as well as chronic low back pain. So in this study, a patient who has severe diabetes and is on gabapentin could have been included because they also have chronic back pain. This patient is at a higher risk for cardiovascular and peripheral vascular disease, which puts them at an increased risk for vascular dementia. You see what I mean? This could confound any effect from gabapentin. Also, without clear information about the timing of the cognitive testing in relation to when they took gabapentin, it's hard to draw a conclusion. So let me say this a different way. Were more people diagnosed with cognitive decline actively taking the medication versus just having had a prior prescription? None of that's super clear. Chronic pain has been shown to cause brain changes on MRI scans. The title of this article is a bit misleading as well because they use the term chronic low back pain. However, they included people with a diagnostic code of chronic pain. Now, this is obviously a generic term, so certainly other painful conditions were likely in the sample. Therefore, we can't conclude that it isn't the painful condition itself that contributed to the dementia, and not simply the medication. Also, interestingly, studies looking at dementia risk in patients treated with gabapentin for seizures have failed to find a link. So this further suggests that some other factor, like maybe inactivity caused by chronic pain, may actually have been the driver of cognitive impairment. Inactivity itself is a significant risk factor for dementia. Or maybe some other health factors like cardiovascular disease or diabetes in combo with the effect of the gabapentin could be the cause, not the medication or the disease on their own. Okay, what's the take-home point here? Should you take gabapentin or not? All right, this study cannot conclude that gabapentin causes dementia or cognitive decline. What it does show is an association. So at the very least, we should be talking about cognitive decline when we think about using this drug. Now, when I prescribe gabapentin or any anticonvulsant for pain, I tell patients side effects typically include sedation, dizziness, blurred vision, feeling kind of cognitively slowed, feeling off balance, nausea, headache, swelling. Now, these all sound awful, I get it. But these side effects are typically mild and dosage dependent, meaning lower doses usually have mild side effects. This is such a commonly prescribed medication because most people tolerate it pretty well. In my experience, gabapentin really falls into the rule of thirds. By this, I mean that about a third of the time it works great. About a third of the time, it helps moderately or a little, and about a third of the time, it doesn't do much for that person's pain. And those people who have pretty dramatic improvement, I would suggest if the side effects are not significant and the benefit is dramatic, that we watch for side effects, including cognitive decline, and use the least amount of the medicine that we need for the shortest time that we need it. But in general, I wouldn't suggest stopping gabapentin in this instance based on the findings of this study. Now, if that patient falls into that middle third, where it helps some, but not dramatically, well, then we need to have a discussion about whether or not the risk of possible cognitive decline is worth it. In a younger patient who might have a longer exposure to the medicine, it would be reasonable to try getting off of it. Sometimes in these patients, we wean off, and the pain is much worse. Pain isn't imprinted well in the brain, and oftentimes we think a treatment isn't working when we've been on it for a long time, but then when we get off of it, we realize how bad the pain actually was. But for a lot of people in that middle third, they may feel a little worse off of the gabapentin, but not so much worse that they actually want to restart it. In the patient who falls into the group not getting relief, it's obvious to me we need to get off of the medication. Sometimes people, they just kind of want to take something. It gives them some sense of control over their pain. But these drugs are not without risk, so I wouldn't stay on them in that instance. Now remember, the gabapentin is a treatment for pain and pain only. It doesn't cure a thing. So if you're adverse to any risk with medications, you have to understand you aren't fixing a problem, you are treating a symptom. When we're talking about pain, not seizures, of course. It does not change the low back anatomy to fix a problem. It doesn't repair nerves to improve neuropathy. It slows down the nervous system, which makes the pain better. Only the patient can decide if the pain relief is worth the potential risk. And I tell people all the time, the pill doesn't know that I want it to work on a specific part of your body. The effects are going to be everywhere. So it makes sense that something that generally slows down the nervous system will have some risks. More importantly, there are other things that we can do that are more successful than pain pills, for neuropathic pain at least. Particularly, spinal cord stimulation and dorsal root ganglion stimulation are very well studied and provide much more relief typically than gabapentin does for back pain or neuropathy pain. Peripheral nerve stimulation also allows us to treat nonspecific low back pain with better results than typically seen with gabapentin. For patients who don't get enough relief with medications, which unfortunately is the majority of patients, these therapies are a much better option. Now, there are downsides to all medicines. Nothing in this life is without risk. So let's not all freak out and stop taking medications with proven track records for neuropathic pain like gabapentin. Remember, all medication classes can have serious risks. NSAIDs are truly life-changing for many patients, but they also cause kidney damage and ulcers and are associated with heart attack and stroke. All bad things, right? Nothing with this without some risk. This study highlights that we do need to consider cognitive decline as a potential risk, but does not show causation. So unless it's making a big difference in your pain, function, or sleep, maybe talk to your doctor about whether or not you want to stay on it. Really, worst case scenario is you wean off, find that your pain is worse, and then need to restart it. Thank you so much for listening today. Please like us, subscribe, share this podcast. We're always working on new episodes for you. Thank you again, and wishing you good health. See you soon.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.